So in the last few minutes in our conversation about frontline ovarian cancer, let's go ahead and talk about combinations. I really only want to spend about 30 seconds per study, and this will be brief. Matt, I want to take you to the first one, which has already been published. It is a combination with chemotherapy, but it's not labeled. Tell us about Velia.
Yeah, so Velia was a very large study, 1,000+ patient study, looking at the idea of using veliparib, which is a PARP inhibitor that you can combine with chemotherapy without too much toxicity. So it's lower dose, can be combined with carboplatin paclitaxel, and then given as a maintenance therapy. I just, cutting to the chase, the take-home message is it didn't seem to matter if you combine it with chemotherapy. It didn't seem to help that much more than what we already have. Do we need a fifth PARP inhibitor? I'm not sure. And I say we'll go to attempt FDA approval, but I'm not sure there's a lot of interest beyond what we already have.
Okay. So another combination obviously is PARP-IO. There's a study called Athena, which adds rucaparib, a PARP inhibitor we haven't really talked about much, adding rucaparib to nivolumab, 400 patients in each arm. So basically take sort of the prima indication of single agent PARP inhibitor, this case rucaparib, and adding an IO to it, niraparib. That'll be very interesting. And the other part of that study, though, is indeed the prima study. So where placebo is compared to niraparib. So there will be two readouts from Athena, one sort of prima-like, rucaparib versus placebo, and that will come first. And then the other one, which will be beyond sort of Athena 2, which will take the single agent PARP inhibitor with nivolumab. So I'm excited about that. And then the obvious question, Shannon, is triplet therapy. Maybe we should add bevacizumab, IO, and PARP. I think there are 3 studies looking at that.
Yeah, so there are, and they're pretty similar. The first study is taking an upfront population. They get a cycle of chemo while they're obtaining stratification factors, and then they're randomized to, there's 3 arms. There's a chemo alone arm, which can include bevacizumab. Then there's a chemotherapy plus followed by a PARP inhibitor maintenance with niraparib. And again, bevacizumab can be included on that. And then finally, there's a chemotherapy with dostarlimab and checkpoint inhibitor with or without, and then including the niraparib. So there's 3 arms, and so we're going to get an idea of PARP-IO, and then bevacizumab's included per investigator choice throughout those 3. And then there are 2 trials looking at combinations with olaparib. Duo-O is looking at the same population up front, response to their either pre or post surgery. They get randomized to durvalumab or chemotherapy with or without durvalumab, and then with or without olaparib as a maintenance. And then similarly, OV46 and OV46 is looking at a similar population with pembrolizumab instead of durvalumab. And importantly, Duo-O allows for bevacizumab, and then the NGOT OV46 is simply the olaparib pembrolizumab question.
Yeah, it's interesting, Matt, to your point with Velia. Do we really need a 5th PARP inhibitor, because talazoparib is approved in breast? You can see with, there's 6 checkpoint inhibitors approved. Dostarlimab, which you talked about, will be number 7. And not only is dostarlimab integrated into this sort of triplet opportunity, but so is durvalumab, pembrolizumab. So it's a competitive landscape. The real opportunity here, I can't remember which of you said, is in the HRP population. We have a 0.43 hazard ratio in PALA-1 in the HRD subset with a doubling of the PFS, and you don't even get the doublet bevacizumab, olaparib, and HRP. And even in PRIMA, where HRP is labeled, it doesn't work well. So I'm really excited about that opportunity. So I'm going to ask each of you for sort of a closing comment, what you're excited about moving forward as this rolls out, as we complete our conversation about frontline ovarian cancer. So Leslie, why don't you go ahead and tell us what you're excited about moving forward as a last comment in the frontline ovarian cancer discussion.
Excited to have options, very excited to have PARP outside of BRCA for sure. And, trying to decide who, who's getting bevacizumab. I think, I'm biased towards Bev. I use a lot of Bev as well. And so just trying to decide who's going to be best for that combination moving forward is where I'm still working.
So, Dr. Beer, as we finish this conversation about frontline newly diagnosed ovarian cancer, what are your closing comments?
Well, I share what Leslie said. It's really an exciting time for our patients. We've, having survived the IP versus IV debates, we're in just a much better period of time, and so it's very exciting. I do think we need to settle this issue as to whether IO works, and in particular works up front. I mean, by testing it up front, we can avoid that issue about, well, the tumors are all beat up and the immune system is beat up. So we need to settle that, and I remain optimistic that it may not be a single agent like Javelin 100, but it may be a combination anti-angiogenic plus IO.
Yeah, as you know, Javelin 100 was just avelumab and chemotherapy. And to your point, we didn't review that negative study, which was presented at the SGO by Jonathan Letterman. It didn't seem to benefit. And if anything, it may even be a little hurtful, although they can't really, make that conclusion. Matt, what are your closing remarks?
Well, so two things. One is we learned a few things during COVID. We probably much more aggressive using neoadjuvant chemotherapy. And I don't think we're hurting our patients. I think the value of the knife is going down. We just reviewed our fellowship data. We're doing much less radical surgery than we used to. And I think our patients are actually doing better, which is really quite exciting. And I think that we like to be put out of a job as an oncologist, but I think we really need to learn how to use these new tools the best. So all these targeted therapies, hopefully they're really helping our patients.
To your point, historically, only about half of gynecologic oncologists give systemic therapy. So who gives the treatments? The medical oncology community is engaged in these conversations. And quite frankly, I think they do a very nice job. But moving forward, we have to teach our fellows, as you just sort of outlined, beyond surgery, because the surgery isn't changing really. So, but the systemic therapy is. So Shannon, you have the last word.
In this group, it's hard because I agree with everybody. No, but I'm excited. I think we have so many options that we've gotten over the last few years. It's, it is so thrilling, but it's kind of like drinking through a fire hose at times, trying to really make those decisions about which things we want to give what patients. So I'm very excited about the results that are going to read out over the next few years from these combination trials. And I remain hopeful that, we'll continue to tease out the HRD test to help it better select our patients.
So I want to thank my panel. I want to thank Dr. Randall, Dr. Beer, Dr. Weston, and Dr. Powell. On behalf of OncLive, thank you so much for being with us, and so long for now.